Perfect. So great. Good morning, all. So, as Katrona mentioned, I'm Steve Kern. I'm the executive director of an entity called Global Health Labs, which is funded from the private office of Bill Gates, based out of Seattle in the United States. So, I'm going to talk to you about opportunities and challenges that link individual and population models for predictive impact in global health, with a focus in particular on clinical pharmacology. Going. All right. There we go. Okay, so there are a couple of pillars of global health disease models that I want to focus on today. And so you're going to see that my talk is going to be way lower on the ground than Francesco's in terms of quantum computing, but I can definitely see some opportunities for quantum in some of the things that I'll talk about. Well, I'm going to talk a little bit about quantitative models for disease progression and therapeutic treatment for individuals. These fit in a number of different titles or categories. They include population PK/PD models, quantitative disease models. The first that produce the right dose for the right patient. The second that give you a sense of how disease progression might be going forward. And then, of course, a lot which we've been hearing about lately is how to personalize these to be able to actually adapt treatment for any individual. But you can think about that not only for an individual, but for a population, a community, or maybe even the world. And then I'll link those into epidemiological models for disease transmission and progression at populations at large. I'm not going to talk much about epidemiological models because Dr. Miriam Njoke Karinja will talk about that in later on in the morning. But I'll just give you a sense of where I think there's great potential to link these two kinds of models together. So models are used across the whole drug development timeline, which is really important to understand. So as we're creating new therapeutics for treating people, we use modeling from discovery all the way through to confirmatory trials, starting off with what are called the quantitative structure activity relationship models, or QSAR models, then physiologic-based pharmacokinetic models, or PBPK models, PK and PD models that you're used to convert effective doses that we've done from experiments and test tubes into animal models. And interestingly, a lot of work is actually going on in silico modeling of physiology to represent and essentially what we would learn from an animal model, so we can limit and perhaps in someday in the future even eliminate animal models. All of that is then used to scale as an estimate of first dose in humans to produce an effective concentration, because we know something about the pharmacodynamics, which is the PD part of PK/PD, which tells us something about the exposure of the drug in the patient versus the effect that's occurring. Interestingly, right now in some diseases like malaria and also in some other infectious diseases, people use what are called controlled human infection models, where we'll actually have people who volunteer to be purposely infected with malaria as a parasite, so that we can study in very detailed, precise ways the effective concentration to clear the parasite. Those give us great insight to go into dose response trials that then ultimately move towards confirmatory kinds of treatments. And so if we can use modeling across this whole format, one of the things that you're starting to see as well, it's not quite ready as Francesco had mentioned for quantum computing, but AI is certainly falling into cover a number of these spaces, particularly in the early discovery phase, where there's a lot of data that lend itself well to artificial intelligence type algorithms and machine learning for being able to predict chemical structure, activity, and then estimate ultimately what might be a physiologic dose to be effective. I'll give you then an example of what happens as we then take these drugs that have been tested and validated in humans and actually then apply them into the real world. Because when you get into the real world, things get oftentimes very muddy and highly variable. And it's important then to be able to go back and look at this modeling and say, what did it tell us about variation that might occur in the population? So this is some data that was done from a group called WARN. WARN is actually a group of researchers that focus on aggregating data that comes in through the clinical world, then look for signs that might tell you something about behavior that might be unexpected for a particular therapeutic. In this case, it's for treating malaria. And the key is to get the right dose for the right patient at the right place and the right time. And an interesting phenomenon they started to notice, if you look at this figure 2 on the left, is that when children are underweight for age, so underweight for age is a surrogate for in essentially meaning that they actually may be malnourished, there tends to be less success in the therapy for a normal dose that's given to children. And that's evidenced by the difference between the pink and the blue bars in the low age groups, 1 to 2-year-olds and 2 to 3-year-olds. And then also interestingly, if you look at the curve on the right, there's a big difference between children who were treated in Africa and children who were treated in Asia, where the variation in terms of response in the Asian population is much greater than seen for the African population, dosed at essentially the same overall dosage level. And so Warren wanted to explore that in more detail. And one of the things then in their further analysis was to aggregate data from a number of clinical trials and essentially put that together into essentially a summarized population study, where on the left curve you see dose exposure curves. So the y-axis is showing the total dose of a particular anti-malarial called lumefantrine versus age, with increasing age on the x-axis. And importantly, notice that the underweight for age kids, so UWA children in the dark bars, are getting a larger milligram per kilogram dose than their not underweight children comparison cohort. And that makes sense because we're basically giving fixed quantal doses to children that we increase at different weight ranges. So if I'm underweight for age, then the number of milligrams per kilogram I'm going to get is actually going up. And so, interesting, what's happening is the smallest, youngest children are getting the largest per body weight dose, but they're showing actually the least effectiveness. And one of the reasons to understand that was to look at this curve at the right, where in fact, regardless of the fact that they're getting a larger dose compared to their normal weight or not underweight cohort, they're actually producing a lower concentration for that larger dose. So that's an interesting and counterintuitive result, that I'm giving a larger per kilogram dose, but getting a lower overall concentration in the body as a result. And why is that? Well, it's one of the unique aspects of children who are malnourished. They, of course, have disrupted normal absorption of anything that's in their digestive system, including pharmacological agents. And so this was a study that was done by Joel Tarning, who's at the Mahidol Oxford University in Bangkok, where he analyzed data that came out of an experiment that was conducted in Niger, where children were treated and provided with anti-malarial drugs as well as supplemental nutrition during the rainy season in Niger. And what you see on this plot is a comparison of an indicator of malnutrition, which is called the MUAC score. It stands for middle upper arm circumference. So it's actually the round circumference around someone's arm versus the percent of a dose that's absorbed. And so you can see the red dots basically indicate the children that are malnourished. The blue are the children that are normal for their weight for their age. And there's the decided difference, almost a linear relationship between this middle upper arm circumference, or this indicator of malnutrition, and how much drug you absorb. And that actually, now that you think about it, makes pretty good physiologic sense. I have a disrupted ability to absorb things because of my malnourished state, and therefore I'm not going to get the dose that I thought I was getting. Even though I've taken it orally, it's not being absorbed and it's passing out of the body without being able to have the effect that we want. And again, I shouldn't be too surprised by that, because we would never really enroll a malnourished child in a very clean, controlled clinical study. So being able to understand these relationships and then incorporate them into modeling gives me some insight into how I might have to adjust the dosages when I run into a population that meets these conditions. And this has then impact on the parameter estimates that go into the models. And the models that we're talking about here so far, are basically first order differential equation models. So fairly straightforward, fairly simplistic mathematical models that nonetheless describe the dynamics of drug absorption and then drug effect in pharmacodynamics. And here are three of the main parameters that talk about the maximum concentration, the area under the curve, or the overall integrals of that concentration curve. So that gives you a sense of how much exposure a person gets to the drug. and also the day 7 concentration. And SAM stands for severe acute malnourished children. And in all cases with the severe acute malnourished children, they have lower levels of all these key parameters, indicating that they're not getting nearly the therapeutic dose. It's not dramatically different, but it's enough to actually cause a significant noticeable number of failures for treating antimalarials. The problem with this also, by treating children with a subtherapeutic dose, is that you run the risk of potentially also setting up for resistance and parasites that then can ultimately survive subsequent dosing in the population. So now we can join forces with this kind of knowledge with epidemiological modelers, and then start to think about how could we implement strategies that would work across a population for a given condition. So here's an example of some work that was done by a team at Imperial College led by Azargani, where they took the pharmacokinetics and the pharmacodynamics. So those are the curves A and B on the upper right side, and C and D is below is the pharmacodynamic. So that's the dose to the effect. The top is the concentration that happens over time, and the dose response curve is curve B. And then implemented that into a population of patients who exist in a malaria region and interface with a number of mosquitoes that then can transmit disease. So given an estimate of what's the biting rate, what's the disease transmission rate, I can simulate how particular therapeutic might be able to actually impact the uptake and the development of malaria within a population that starts off essentially without disease. And in this case, it's with the anti-helmintic drug called ivermectin. Ivermectin, of course, had tons of notoriety and fame during COVID. It actually is an extremely effective anti-parasite drug. It kills a number of different pathogens, including mosquitoes who bite someone that has a significant level of ivermectin in their bloodstream. And so what you see on the bottom left curve then is the rapid diagnostic test positivity, so the degree of patients or subjects who have malaria, and you see that dropping over time very quickly, but not being sustained after dosing with ivermectin. So putting these together gives us some idea of how often would we have to dose ivermectin to be able to sustain a therapeutic concentration that would cause a reduction in the degree of disease transmission that occurs in a population. And you can see in the curve D on the left side, if I give ivermectin with the normal antimalarial therapeutic, I can start to flatten those curves and sustain a longer period of time where I don't have disease present. And so now I can then also—
Steve, if we could start to just, there's so much in this, but if we could start to wrap up, that would be
perfect. Great, I'll do that quickly. This just is something that shows how you can do this with a novel delivery system. And I'll go one more step and just say, and you can then add greater elements of dimensionality by looking at factors such as how the disease spreads in different geographies, how you might simulate it in different levels of granularity, pixel, say, versus a province versus a national level, coupled in an epidemiological model to estimate then the cost and the effectiveness that can actually come together. And so this huge amount of dimensionality can actually be used to then ideally plan strategies for treating disease. So in summary, combining forces with other modeling communities, we can really get a sense of how individual drug level impact can actually be modeled up to a whole population. And working with spatial epidemiological modelers, we actually have a great benefit to explore the cost and the benefit of new therapies in this disease, among others. So I'll stop there, and thanks, Katrina.